Hello, my name is Tammy Yulin, and I am the Universal Newborn Hearing Screening and Intervention Program Coordinator. This e-course is to introduce the guidelines for Georgia Public Health Hearing Screening by Audiometer Training Manual. The manual outlines procedures for conducting behavioral hearing screenings by audiometer for children aged 3 years and older. I will be discussing the following: rationale for hearing screening beyond the newborn period, selecting screening site and arrangement, selecting an audiometer, audiometer mechanical function check, screening procedures, infection control, and care of the audiometer. Why screen for hearing loss? The purpose of hearing screening beyond the newborn period is to detect late onset hearing loss to minimize delays in academic achievement and developmental delays, especially speech and language. Congenital permanent hearing loss occurs in approximately 2 to 3 per 1,000 live births. The prevalence of hearing loss doubles during early childhood and is estimated at 5 to 6 per 1,000 children. Screening for hearing loss in early childhood will also detect children with hearing loss that were not identified during the newborn period. It is recommended that the facility's screening schedule follows either the American Academy of Pediatrics Bright Futures periodicity schedule or the American Academy of Audiology Childhood Hearing Screening Guidelines. Regardless of which screening schedule your facility follows, if the parent or teacher has concerns about a child's hearing, a hearing screening is to be conducted to rule out hearing loss. Selecting a screening site. An appropriate room will be away from main hallways and facility noise and free from ambient noise from fans or other utilities. Avoid rooms with loud ventilation or with air conditioning units outside the window. Also avoid rooms with all hard surfaces because the acoustic properties of these rooms are highly reverberant and do not minimize ambient room noises. You would want to select a room with carpeting. Rooms should be uncluttered and free of visual distractions. Avoid mirrors or reflecting surfaces and windows. The room should be quiet enough so that when a screener puts on the audiometer headphones and sets the audiometer at 500 Hz, a 10 dB tone should be audible. At 1000 Hz, a 10 dB tone should be audible. At 2000 Hz, a 10 dB tone should also be audible. And also at 4000 Hz, a 10 dB tone should be audible. Room arrangement. Children need to be seated so that they cannot view the audiometer. Avoid seating a child facing a window. This is too distracting. If mass screening, space children far enough so that the individual instruction can be provided without distracting other children. Selecting an audiometer. When selecting an audiometer for a screening program or location, it is recommended that the audiometer be a single channel with 2 earphones. Preferably, the earphones will be circumaural headphones. The audiometer should be capable of testing frequencies ranging from 250 Hz through 8,000 Hz. The loudness level should be capable of presenting tones ranging from 0 dBHL through 90 dBHL. Screening audiometers that have limited frequency and loudness level operation are discouraged. Although they cost less than a single-channel audiometer, screening audiometers lack functionality and flexibility. We recommend selecting an audiometer that is portable, lightweight, and durable. The power source can be either battery-operated or plug-in. Audiometers should be calibrated to the current standards developed and adopted by the American National Standards Institute. Audiometer mechanical function check. Complete the following before conducting hearing screenings. Turn on the audiometer and wait 10 minutes. Check the mechanical function by completing the checklist. Power on. Make sure there is power to the audiometer when the switch is turned on and the audiometer is plugged in. 2. Jacks seated. Make sure the jacks, where the headphones and power cord are plugged in, are in the proper receptacle and are pushed in all the way. Occasionally moisten the receptacle with an alcohol wipe and push into the jack and rotate. This breaks up dust. 3. Earphone cushions. The cushion should be clean, flexible, and free from breaks or tears. Cushions should be cleaned with mild soap and water. Never use alcohol wipes on the cushion, as this breaks down the earphone cushion material. 4. Dials tight. Turn the frequency and attenuator loudness dials to check for slippage. Loose dials should be tightened before the audiometer is used. 5. Headband tension. Put on the earphones. There should be enough tension so that when positioned on the head, The earphones rest snugly on the ears. 6. Cords okay. While wearing the earphones, present an audible tone to the right earphone. Gently twist the cord by the right earphone and at the jack position. Repeat for the left ear. If the sound cuts out or becomes scratchy, the connections must be tightened or cords must be replaced. If static is heard, static may indicate dirty contacts. Clean the contacts by rotating the dials quickly. 7. Volume increase, decrease. Present a tone to one ear and then increase and decrease the volume of the tone. Ensure change in volume when volume wheel is turned. Repeat for the other ear. 8. Pitch change. Present a tone to one ear and then increase and decrease the pitch for all the testing frequencies. Ensure change in the frequency when dial is manipulated. Repeat for the other ear. 9. Tone presenter. Press the tone switch button and the sound should be audible and present. The tone should be audible when pressed and discontinue as soon as switch button is not deployed. Check both tone presenter switches or buttons if the audiometer is so equipped. Number 10, crosstalk. As you listen to the left phone with the sound presented, no sound should be present in the right phone, and vice versa. If any one item is not functioning correctly, troubleshoot or contact manufacturer or dealer. Checking function prior to using is important to minimize the number of children that are referred unnecessarily. If parts of the audiometer become worn and no longer function, it is not allowable to interchange parts between audiometers. Contact the audiometer dealer to obtain replacement parts and for the machine to be calibrated. A log to indicate and track audiometer function is suggested to ensure all performance checks are completed. An example log can be found in the manual's appendix, Appendix A. Once the mechanical check is completed and there is no indication of possible equipment failure, set the audiometer to present pulse tone. If the audiometer does not have pulse tones, it is okay to use a steady state tone. Pulse tones are recommended so that if there is any ambient noise in the room, the tone is easier to differentiate from background noise. Hearing screening procedures. Before performing a hearing screening on a child, a case history should be obtained. The objective is to determine if the child may be at risk for a hearing loss or is demonstrating signs of hearing loss. Questions should be reviewed with the parent or caregiver and child when age appropriate. Child is asked to report any complaint about their ears. Parents or caregivers are asked to report any abnormal listening behaviors. Positive findings should be documented in the patient's file when applicable. If abnormalities are present or there are any overriding concerns, refer the child for further evaluation. Some complaints are cannot hear, difficulty understanding, pain in the ear, fullness in the ear, drainage from the ear, difficulty with phonics, frequent mistakes in following directions, tires easily. Some behaviors are tugging at the ear, asking to have things repeated, turn side of head towards the speaker, inattentive in class, watches speaker's lips, shows strain when listening, has a speech problem, or tends to be passive. A visual inspection of the ears should be conducted prior to proceeding with hearing screening. It is important to check for signs of ear disease and or abnormal development. When conducting mass screenings, at minimum, an external inspection of the ears is to be completed. An internal inspection may be deferred if staff does not have training in otoscopy or time does not permit. If any significant abnormalities are observed through visual inspection, the child is to be referred for medical evaluation. Additionally, if the child currently wears an assistive listening device such as a hearing aid or a cochlear implant, the child should not be screened for hearing loss. Children that utilize assistive listening devices such as hearing aids have already been identified with hearing loss and should be referred back to their primary care physician or audiologist for testing. External. Inspect the pinna and the area around it for set position of the ears, skin tags or pits, tenderness, redness or edema, signs of drainage or wax buildup in the canal. Document positive findings observed through visual examination in the child's record and on a parent letter, Appendix D in the manual. If there are signs of drainage or foul odors are present, do not screen. Refer to primary care physician for medical management. Instruct the child to raise their hand when a tone is heard. Example instructions. I am going to place these headphones on your ears. You are going to hear beeps. Every time you hear a beep, 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 raise your hand as fast as you can. For the purpose of the screening, the child can raise either hand in response to hearing an audible tone. It is not necessary for the validity of the screening that the student raises only the hand on the side they hear the tone. It is acceptable to adapt the task, high five, placing a peg in a board, etc., for the younger child. When providing instructions, it's important to show enthusiasm for the task. Depending on the child's reaction and age, asking the child after the instructions what they are supposed to do can be useful to determine level of understanding. Place headphones securely over the ears, red on the right ear and blue on the left ear, and tighten the headband. Do not allow the child to put on the headphones themselves. Remove eyeglasses, headbands, large earrings, etc., and place hair behind the ears to ensure secure placement of headphones. Proper placement of headphones should be visually inspected to ensure that headphones are secure with no gaps between earphone and the side of the head. Do not put extra pressure by holding down the headphones during screening. Holding down the headphones can cause the ear canal to collapse. Present the 1000 Hz 50 dB HL conditioning tone for 1 to 2 seconds to the right ear. If the child does not respond, re-instruct the child and represent tone at 50 dB HL. If no response after 2 presentations and re-instructions, it is suspected child does not understand task, proceed to attempt play audiometry. If the child responds appropriately, turn to 20 dB HL, present tone at 1000 Hz, then 2000, 4000, and 500 Hz. Turn selector switch to the left ear. It's optional to tell the child being screened when you are changing to the other ear. Again, present the tones at 1000, 2000, 4000, and 500 Hz. If the child responds appropriately for all 8 tones at 20 dB HL, the child passed the hearing screen and headphones can be removed. If the child did not hear 1 or more tones in either ear, turn the dial to 25 dB HL and immediately rescreen both ears at 25 dB HL at 500, 1000, 2000, and 4000 Hz. If the child hears all 8 tones at 25 dB HL, the child passed the hearing screening. Seeing the child's eyes and facial expressions is helpful in determining the accuracy of responses. However, it is important that the child not see the tester's hands, the audiometer, or the screening record form. If you have to use play audiometry for younger children or a child with a developmental delay, it is a modification of the standard pure tone screening procedure in which the child is conditioned to respond to the sound by performing a task, such as dropping a ball in a bucket or giving a high five to someone assisting with hearing screening. The purpose is to incorporate a fun and engaging task that encourages the child to participate and is developmentally appropriate for younger children being screened for hearing loss or with a developmental delay. The screening levels, frequency, and the pass referred criteria remain the same. You're going to place the headphones on the table facing the child with the audiometer set at 2000 Hz and at a 60 dB HL tone to ensure the tone is audible. Screener will hold the toy near their own ear and assume a listening attitude and present the tone. Indicate through facial expressions, and you can also say, "I heard it," that the sound was heard, and then drop the toy in a pail. This may be repeated as often as necessary until the child shows interest. Screener offers the toy to the child and places their hand on the child's to guide the first responses. Encourage the child to wait until the sound is heard. When the child appears ready, present the sound and guide the child's hand to put the toy in the container. Child may give consistent responses after only one demonstration or may need several to respond on their own. Demonstrate first without and then with the headsets on. Once child is conditioned task with headphones on, proceed with the hearing screening. A pass result. Child hears all 8 tones at 20 dBHL or 25 dBHL at 500, 1000, 2000, and 4000 Hz. Other than for training purposes, it is important that the decibel level, 20 dBHL for initial screen, 25 dBHL for immediate rescreen if appropriate, be adhered to throughout the hearing screening. The screening level is not to be increased if a child fails to respond greater than 20 dBHL for initial screen and 25 dBHL for immediate rescreen when appropriate. Rescreen refer. Missing a single tone in either ear results in the child not passing the screen. Screening level for rescreen may be conducted at 25 dBHL as stated previously, and it is optional to have a second immediate screen to be conducted by a second different screener. If time or site protocol does not permit immediate rescreening, hearing rescreen should be scheduled for not more than 2 weeks out from initial screening. For children not passing the immediate rescreening or rescreening at 2 weeks, the child should be referred to their primary care physician or audiologist for follow-up. Results of the screening should be documented in the child's record and on Form 3300, Appendix E in the manual when appropriate. Parents should receive notice of hearing screen results in writing and verbally when present. Appendix D in manual has written notification sample. It is optional for the primary care physicians to receive notice of hearing screening results in writing. It is also optional for facilities performing mass screenings to keep a log of children who pass and refer screening to determine overall refer rates. Referral rates on screening should not exceed 10%. If rates exceed 10%, programs should consider retraining staff conducting the screen. Common errors in screening: inaccurate or unclear directions to the child, such as providing instructions in a non-native language or by using words that are not developmentally appropriate for the child. Child in direct view of the audiometer control panel or the motions of the operator. Earphone on the wrong ear. Visual cues given through eye movement or body movement by the examiner. Repeating tone presentation multiple times when the child does not respond on the first attempt. Tone presentation in a rhythmic manner. Unnecessary talking during screening. Fatigue caused by extended screening time. Each child fatigues during screening at a different rate, depending on variables such as age, attention span, interest in task, etc., and also a rush screening process. Infection control. Be sure to wash your hands or use hand sanitizer before and after every hearing screening. Wear bandages and/or gloves if cuts or open sores are on your hands. Avoid wearing rings and jewelry to allow for proper hand cleaning. Do not allow any food or beverage into the screening area. Wipe down headphones, cables, and equipment daily or as needed when visibly soiled. Do not allow children to touch equipment. Care for audiometer. Handle the audiometer gently and avoid dropping or using rough treatment. When transporting the audiometer, place in secure locations so that it can't fall during a sudden stop or slide during a turn. Avoid extreme temperatures below 32 degrees or above 90 degrees. Keep all cables, cords free of tangles and twists. Check all electrical connections, dials, and switches for signs of problems. The earphone jacks should be occasionally removed from the plugs and wiped with an alcohol pad to improve the connection. Proper care must be taken to prevent moisture from getting inside the audiometer. The case should be kept closed to prevent dust buildup. If case or exposed surfaces become dirty, soap and water is usually sufficient to clean them. Mechanical and biological function checks must be done each day on each audiometer before use. Clean headphones routinely with cleaning agent, alcohol-free wipes. Do not use alcohol because it may dry out the rubber cushions on earphones. When the earphone cushions need cleaning, remove them from the headset, clean and dry thoroughly before replacing. Keep all moisture away from the diaphragm, the hole in the center of the earphones. Yearly calibration. An electrical calibration check needs to be done yearly by a trained professional. If you are unsure where or how to get the equipment calibrated, Call the state office for assistance. It is recommended but not required that an extensive calibration, which includes internal cleaning and lubrication, be done at a repair facility or the factory about every 5th year. Having an extensive calibration performed may extend the life of the audiometer. The audiometer needs repair if tone does not sound normal or sound is not produced when tone lever or button is pressed or static is heard. Earphones do not remain in proper position over ears. A dial or switch does not function or indicate lighters do not illuminate. Thank you for your attention during this e-course.